Good morning, Dr. Patino here at the Cosmetic Surgery in Costa Rica. We're going to do micro power assisted liposuction, and we're not going to do a fat transfer today on this patient, but even though we're not doing a fat transfer, notice how whatever we're going to do here is we're going to obtain yellow beautiful fat, which we don't need to because we're not going to do a fat transfer, but we do it still so that the patient doesn't have anemia, unnecessary blood loss, right? Need for a blood transfusion, which we never have to do, thanks to God. Need for reoperation, which we never have to do, thanks to God, secondary to bleeding, right? So that's very important. We don't even have a cell saver here. We don't have, and we don't need a cell saver to transfuse the patient, right? Because some surgeons routinely transfuse the patient's own blood that has been lost. It is so much that you need to do that, right? That is putting the patient at an extreme, you know. We used to do that routinely when I used to do emergency open heart surgery when the patients were bleeding to death. Yes, of course, you gotta do that, right? But in the open heart surgery, you know, you have a heart lung machine that recirculates your own blood, but that has extra risk. Why put a healthy patient for cosmetic surgery through such a high risk, right? We don't do that. So our patients, instead of losing 1 or 2 cups of blood, as you can see with this surgery, they lose maybe 1 teaspoon. It's minimal, the amount of blood loss, so they don't need blood transfusion intraoperatively of their own blood. That's called an auto transfusion, and it's done with a cell saver. And they don't need blood transfusion from other people either, right? Because look at this, there is no blood loss. Look at that. What is the color of that output?
It's yellow fat.
Man, this would be great for a fat transfer, right?
Right.
Because there is no blood there is no oil. But I still look at my strokes. I still do very, very slow strokes. Let the tool do its work. This is micro power assisted liposuction. But it's not the tool itself. Many surgeons have this same tool, right? It's how you use it, right? It's similar to a toothbrush, an electric toothbrush. This is similar to an electric toothbrush, right? Where the tool vibrates, right? So you don't have to be jamming it like an old toothbrush and cause gum bleeding. But if you have an electric toothbrush and you jam it back and forth at full force and speed, there is going to be bleeding. There's going to be gum bleeding. So it's the same principle. It's not a perfect analogy, but it's very similar. So the fact that you do have the tool doesn't mean you're going to do the job like we do. So, and there is many things that go into it. It is not just this. It is what you tell the patient. So we tell the patients not to take any aspirin-like medications, not to take any herbs, no vitamins of any kind, no Motrin, no ibuprofen, right? And we do that for 2 weeks before and 2 weeks after the procedure, right? And it's also what the surgeon does. Some surgeons do routinely give aspirin and ibuprofen. They actually even prescribe those things, and even herbs and things like that, right? And some surgeons routinely give blood thinners like enoxaparin or heparin, right? And we don't do that, and we never done that, and will not do that. So the important thing to prevent a blood clot is not enoxaparin, it's not heparin. That's good. And it's good medical practice for surgeons that do that. But we don't do it because our patients ambulate, our patients walk. The best way to prevent a blood clot is not enoxaparin, it's not heparin, it's not lathamus or aspirin, right? The best way is to, number one, do adequate patient selection. If you have a history of a blood clot, no, I'm not going to operate on you. And yes, you're going to need blood thinners if somebody operates on you, right? But to do cosmetic surgery on patients with a high risk of a blood clot and pulmonary embolism and death, it's not worth it for me. So I don't want to put my beloved patients to such a risk. I just don't do that surgery. So number one is patient selection, right? Our patients are healthy, you know, or they have a medical condition that is well controlled, right? And then number two, the use of compression boots is very important, and we use them routinely. Not only do we use them, but we go thigh high. We go the extra mile, because most surgeons just use knee high, and that's not a big deal because they have done studies that even if you put it in the arms, it still works. But our statistics are incredible, and so we're not going to change that. I believe that it's important to do them despite of the studies, because most blood clots arise from here, not from below the knees. Most blood clots arise from the thighs, so we stimulate the thighs as well. Of all that is early ambulation, meaning our patients, you can see them walking on TikTok the same day of surgery, right? And our patients usually walk 1 mile the first day, 2 miles the second day, 3 miles the third day, preventing a blood clot and preventing death. And thanks to God, we never had anybody die from cosmetic surgery, and we want to keep it that way. So we have a long-standing record of this technique working, right? And it's also the tumescent anesthesia, right? So the tumescent anesthesia that we put has epinephrine to clamp down the blood vessels so that there is no bleeding. And of course, with the traditional technique, the patient is going to be in severe pain. The patient is not going to be able to walk. So of course, that's why if your patients are in severe pain and they're not going to walk, they're not going to be pumping the blood. Yeah, of course you need a blood thinner and aspirin and all that, right? But our patients don't. Why? Because it's different. It's a different technique, right? Our patients walk, and by walking, they're pumping with their muscles. As the muscles contract, when you walk, you pump the blood. That's the best way. No blood thinners. But if you're in a hospital or in a clinic and you're restricted to bed, yeah, you bet you're going to need blood thinners. But you're not going to be able to get this beautiful bloodless aspirate. Thank you very much for your attention. Wow. So, notice this incredible. I mean, I see this file and I'm thinking, man, I wish he had a fat transfer to the bottom. She didn't want to, but look how beautiful this is, and look how my strokes are very slow and calculated. This also decreases the risk of intra-abdominal organ injury, something that has never happened to me, thanks to God. I believe that usually happens to a very fatigued surgeon that's going at full speed, maybe tired from doing many cases on a Friday afternoon, just like today. Today's Friday, we're just doing one case. But these surgeons, usually do 10 cases per day or more, or less, depending on how many cases you do. But if you do many cases per day, you're not going to be able to obtain this incredible aspirate, right? Ramon, you've been an anesthesia provider for how long?
I'm going into my 5th year of anesthesia now.
5th year. Why don't you show Ramon over there? And what do you see, Ramon, that's different here when you do cases somewhere else? Because you come here occasionally, and but you work at other places, hospitals and surgery centers. So what do you see here that's different, and how does that make your life easier?
I see a lot of difference here. So one is how meticulous you are. And as far as adipose tissue that's coming out, it's, like you mentioned, bloodless, very clear, yellow fat, and that helps me out a lot because he's not experiencing a lot of bleeding on that side of the grade. It's reflected over here with my vital signs. The patients are a lot more stable, they maintain their blood pressures a lot better, their heart rates are a lot more, and as I was mentioning, my vital signs are a lot more steady. The less changes are happening on his side of the drapeid, the less medications I have to give. If the patient gets less medications, they recover a lot faster, and how he was mentioning, right after surgery, and again, it's incredible because I don't see it anywhere else. The patients are walking. They're not groaning, they're not grimacing, they're not holding tension because of pain they're experiencing. They're actually up and they walk out of surgery and they start exercising, which further prevents any complications that we want to see. And again, I don't typically do not see it anywhere else like the way I see it done here in this surgery center.
Wow, well, thank you so very much. And what about nausea and vomiting? That's a common side effect from the anesthesia, right? Do you need to give less of those medications, narcotics, and as a result they have less nausea and vomiting?
Yes, I do see a lot less nausea and vomiting, but again, it's also because one of the big factors is we see a lot of decrease in our bleeding. So because there's less shifts in how much volume is in the body, the patients do experience less bleeding, less nausea. We can limit the amount of fluids we give, and because of the technique that our amazing doctor uses, I do see less pain. And because there's less pain, I don't have to use as many opiates. And opiates are a very nasty drug that we want to limit as much as possible because it decreases respiratory rate, increases length of stay here because they're a lot more drowsy, can even increase the rate of pneumonia afterwards. And based on his techniques, I don't really have to give that much opiates. And the patients experience a lot less pain, they're a lot more mobile, they're a lot more quick to recover from. That is correct.
Wow, man. So we have the best of the best. Incredible, incredible. Thank you. Wow, look at that aspirate. We're almost done with the abdomen, and look at the aspirate still, like you said, almost white. Incredible. There's just no bleeding at all.
It's glowing, doctor.
I know. Thank you. I'm ambidextrous, but I'm using my non-dominant hand here. So if you're a surgeon and you're not ambidextrous, most surgeons are ambidextrous, but if you're not, try your non-dominant hand. And what that's going to do is that's going to make you go slower. And when you go slower, your chances of getting an aspirate like this is better. It's almost bloodless, And it also, especially if you do many cases, it will also decrease your risk of occupational injury in the form of tendinitis to the elbow or shoulder or to the wrist. Now we talked about what I can do by not stimulating the patient, because the patient is not, she has tumescent anesthesia, so she's not stimulated, so there is no significant swings in blood pressure, right? That's what I can do for the anesthesia provider, but what does the anesthesia provider do for me? Well, he maintains the blood pressure, right? At a normal range, because if the blood pressure is super high, then there is going to be bleeding no matter what I do. Thank you. Wow, look how comfortable I am, not sweating it at all. We're almost done. Look at the output, still incredible, right? Incredible yellow. What color is that output, Emily?
Wow, it's yellow.
Yellow, beautiful, right?
Oh, yeah.
I'm going to show you what is called the pinch test, you guys. So that's something that we routinely do in surgery. And I'm going to show you what the pinch test is going to be, so that but can you see how marked she is? Can you see the semilunar lines on either side?
Yeah.
And can you see the linea alba in the middle? And look at the aspirate, it's incredible. So now I'm going to show you what is called the pinch test. I don't know if you can see it from over there. You see?
Oh, yes.
This is 0.5 centimeters.
I see it.
Incredible. 0.5 centimeters everywhere we go. Look at this, see? 0.5 centimeters here too. See?
Oh, yeah.
Very incredible. We're gonna take some photos so you can see the transformation on this lady. Thank you. So this is her waist. Look how beautiful she looks. I mean, she literally had a big bump here. Now we smooth her out, and that's her right side, right? And so this is the pinch test, you guys. This is incredible, right? Like 0.5 centimeters, right? Everywhere we go, right? I can go this way too, see? I don't know what's easier for you guys to see. Maybe this
Oh, we're
way.
seeing it all.
We're seeing it all. Look at that, see? Beautiful. Everywhere you go, see? It goes all the way up, see? Everywhere. Look at that. Incredible. Beautiful. And we're gonna turn it to the other side now. We'll show you. See? So this is the other side. Look at this, see? Like a little mountain here. We're gonna make it the other way, right?
Yes.
It's a concavity, we're gonna make it a convexity. Because Gabriel Patino is convex. I'm kidding. So anyway, so that's what we're gonna do. So this is where the waist is gonna be all these, look at all these spots, man.
Yeah.
See? And now we're gonna turn it into what you saw, the pinches. See the pinches here? It's incredible. There's a lot of fat here, you know. Thank you. Wow, and look at the aspirating, man. Still yellow, beautiful fat, huh?
Wow.
It's unbelievable. It's like gold. Bloodless and oilless. Too bad she's not gonna have a fat transfer to the buttocks, man, because she's looking good, man. Look at that. But we're gonna take all these mountains down. Look at these. It's even more impressive here. Look at this. See?
Oh yeah,
Wow.
gorgeous.
Yeah. Look at that. That's the pure fat right there coming out. Oh, this makes me so happy. And her patients do so well. You're gonna probably see her walking out of here like nothing happened. Maybe like she just went to the gym or something. Incredible. Thank you. Look at the waist on this other side. So this is the other side, buttocks over here. Look at that. See? It's still. You see that? Wow. Look at that. It's still, you know, no, this is called the pinch test. But you see, 0.5 centimeters everywhere you go. Incredible. Look at that. Thank you.